Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice. That is Hatvet's YouTube channel. We are thankful to Dr. Vinod Kumar for sharing his practical tips with fellow veterinarians.
Hello, my dear friends. We have discussed about the anatomical peculiarities of the chest, the different cavities of the body and their peculiarities, the thoracic cavity or the chest cavity, the peritoneal cavity, pelvic cavity, their peculiarities in different species, difference between the human pelvic cavity or the human body cavities and the animal body cavities, then the chest of dogs, the different structures inside the chest of dogs, except the heart, the mediastinum, the two halves of the thorax, the left and the right thorax, the pleura, its anatomical positions, its reflection, the mediastinum formation, structures inside the mediastinum, the lungs, anatomical peculiarities of the lung, both the halves, positioning of the heart, positioning of the mediastinum, different lobes of the lungs, the bronchus, bronchioles, the trachea, carina, some diseases, etc. Now, after coming through this basics of thoracology, now we are today dealing with the commonly found different diseases in Indian field conditions and their management, their diagnosis in the field with all available amenities in the field and their management in the field situation. Let us refresh our thoughts yesterday. The lung, the canine and the feline lungs, this is the left lung, this is the right lung. The left lung has two lobes, the cranial lobe and the caudal lobe, which is clearly demarcated by the interlobular fossa. Then the cranial lobe is again subdivided into anterior lobule and the posterior lobule, that is the cranial part and the caudal part. This is the cranial part of the cranial lobe, this is the caudal part of the cranial lobe, and this is the caudal lobe. So that is regarding the left lung. This is the right lung. You can see the cranial lobe, entire cranial lobe, and there is a middle lobe, there is an accessory lobe, and there is a caudal lobe. So we saw it yesterday, and coming as other schematic representation, this is the right side and this is the left side. The tilting of the heart is towards this left side. The right has 4 lobes, the left has 2 lobes, and the anterior, the cranial lobe is again divided into cranial part and the caudal part. In the caudal lobe, the accessory lobe, caudal lobe, middle lobe, cranial lobe. Actually, all these things can be, to a certain extent, be seen in radiographs. See, just an introduction to the feline lungs. Yesterday we saw the feline lungs the same as that of the dogs. It has the laryngeal cartilages, the trachea, tracheal rings, the tracheal bifurcation, and the bronchus, the bronchioles, everything can be seen here. And the lobes of the left side, lobes on the right side, is everything same as that of the dog. On deflation and inflation of the lungs. Now, we are taking particularly the lung diseases. Now, what shall be the symptoms of a lung disease? Definitely, lung is the main organ for respiratory functioning. Always 24 hours, air is coming inside and going out. So we have inspiration and expiration. And so yesterday I mentioned about the tidal volume. Yesterday I mentioned about the minute volume. These two are very important. So for maintaining this tidal volume and minute volume, tidal volume into number of respirations per minute will give the minute volume. So for maintaining this, a normal healthy lung is needed. When there is a lung pathology, definitely this alters. So when this is altered, definitely the oxygenation level of the blood also becomes altered. So in order to increase the oxygenation level of the blood, what should the body be doing? Definitely it will be increasing the number of breaths per minute, the rate of breaths or the rate of respiration. So a polypnea develops. And there will be increasing in the depth of respiration. So ultimate outcome is there will be a forceful inspiration. A forceful inspiration. That is the outcome, or a forceful expiration. That is the outcome. That means a respiratory distress. We say as a dyspnea. Dyspnea means difficulty in respiration. So that is the outcome of a lung disease, whatever it be. So respiratory distress and cyanosis is the number one symptom in a lung disease, whether it is acute or chronic. Cyanosis means, as we know, when there is reduced oxygenation of blood, the tissues will be discolored. There will be a slight bluish tint. It will not be blue like this. Only there will be a slight bluish tint. This bluish tint we term as cyanosis. Cyanosis, most of our doctors might have noticed cyanosis in a lot of diseases. So cyanosis is a clear sign that there is reduced oxygenation of blood. There are certain technical terms that we use. Anoxia, hypoxia, hypoxemia, etc. See, there is a technical term which is used as a wrong usage, hypoxia of the blood. There is no hypoxia of the blood. The hypoxia of the hypoxia of the blood has a typical name. It is hypoxemia. Hypoxemia. There is no anoxemia because the animal cannot survive. Anoxemia means no oxygen in the blood. Like we term anemia. There is no such condition, anemia. It's only a relative function. It's a relative technical term. It is only hypemia. Anemia means no blood at all. Can a dog survive in no blood at all? No. So it is hypemia. Here also it is hypoxemia, not anoxia. Anoxia is just a technical term to show the severity of the hypoxia. Anoxia. Of course, we used to find out hypoxia and hypoxemia by our pulse oximetry. We also have this machine, and so respiratory distress and cyanosis are the number one symptoms of a lung disease. Then secondly, we have nasal discharges. The nasal discharges may be purulent or mucopurulent or mucoid or hemorrhagic. Okay, 4 types of nasal discharges are there: mucoid, mucopurulent, purulent and hemorrhagic. Mucoid discharge means it is only thin watery discharge, that is catarrhal discharges. Pure technical term is catarrhal discharges. Then second is mucopurulent. Then second is purulent. Purulent means there is some sort of suppuration. Pus is formed and is flowing out from the nose. So it shows an infectious disease of the respiratory tract. Catarrhal nasal discharges can even form from non-infectious conditions like allergic rhinitis, allergic tracheitis or tracheobronchitis, allergic laryngitis, etc. This type of catarrhal discharges can occur. But if it is changing to an infectious condition, there will be purulent discharges. If it is extremely infectious, lot of pus will be coming out. We say as pus from the nose. That is a purulent nasal discharge. And sometimes a less acute infection can produce a mixture of purulent discharges plus mucoid discharges. So it will show a mucopurulent discharge. Okay, for example, in canine distemper, it is not necessary that a purulent discharge can happen. Could be mucopurulent discharge. So sometimes blood may be flowing out. A hemorrhagic nasal discharge. Hemorrhagic nasal discharge. Sometimes there will be some trauma inside the nasal tract, polyps inside the nasal tract, tumors inside the nasal tract. All these can produce hemorrhagic nasal discharges. And from the nasal discharge itself, we can judge approximately what the problem is. Then third is acute and chronic cough. Why there is cough? See, cough is a natural body mechanism by which it is a collective effort of the intercostal muscles, the diaphragm and the stomach, that is the rectus abdominis muscle, by which it is abruptly pressing the lungs and squeezing the lungs so that some irritants or some unwanted elements in the respiratory tract is blown out. That is cough and sneeze. Why there is a cough in a respiratory disease or a lung disease? All the time irritants are being irritating the respiratory mucosa. So also exudates are formed. These exudates have to be expelled. For that, the cough reflex occurs. So acute and chronic cough indicates that is what it indicates. It is a symptom of lung disease. Not only even in lung disease, in bronchial disease or even some lower tracheal disease also, this can occur. So acute and chronic cough. Panting. Definitely. Why there is panting? Because due to the lung disease, there is hypoxemia, and all the time it is struggling to get the breath. It is panting. Common. So panting is a symptom of lung disease. Hypoventilation. Ventilation, as we know very well, the air, inspired air, will go inside through the nostrils or through the mouth. It will go inside, passing the larynx. It will be going inside the trachea. It is humidified. It is passed into the bronchus, then bronchioles. After the bronchioles, it establishes its occurrence in the alveolus. So in the alveolus, the mucosal borders or the epithelial borders are taking part in the exchange of the atmospheric oxygen into the hemoglobin. So capillaries will absorb the oxygen, will be transferred into the RBCs. So when this is law, when the inspired air is low in volume, the volume of the inspired air is low due to the lung disease, what will happen? This diffusion becomes less. We say it as a hypoventilation. Then inspiratory dyspnea. Generally, inspiratory dyspnea is a symptom of the upper respiratory tract, and expiratory dyspnea is a symptom of lower respiratory tract. Sometimes in some conditions, inspiration dyspnea can happen when it is associated with upper respiratory tract also. Okay. So yesterday I told about the dyspnea. There are 3 types of dyspnea. Which are they? We have the inspiratory dyspnea. This is inspiratory dyspnea, whereas there is narrowing of the aperture of the larynx. This is inspiratory dyspnea. So inspiratory dyspnea occurs when there is narrowing of the upper airway tract. Suppose we can say there is a laryngeal paralysis. So the lumen closes and there will be inspiratory dyspnea. And just opposite to it is a expiratory dyspnea. This is expiratory dyspnea. Exactly, this is the expiratory dyspnea. So expiratory dyspnea is not an issue of the upper respiratory tract. It is an issue of the lower respiratory tract, such as the bronchioles, the bronchus, etc.
Hatvet Pharma launches Hatclav 250 syrup and Hatclav 500 tablets. Amoxicillin and clovenic acid in the ratio 4:1, which is required for our pets. Hatclav, potentiated aminopenicillin systemic drug. Amoxicillin plus potassium clovonate. Bactericidal aminopenicillin with beta-lactamase inhibitor with extended spectrum of antibacterial activity. Amoxicillin and potassium clovonate oral suspension, Hatclav 250 suspension. Amoxicillin 200 mg plus potassium clovonate 50 mg per 5 ml. Indications: broad spectrum antibiotic for bacterial infections, skin, soft tissue and UTI infections. Dosage for dogs 13.75 mg per kg every 12 hours. For cats 62.5 mg per cat every 12 hours. Route oral. Presentation 30 ml. Amoxicillin and potassium carbonate tablets had CLAV 500 tablets. Amoxicillin 400 mg plus potassium carbonate 100 mg. Indications: broad spectrum antibiotic for bacterial infections, skin, soft tissue and UTI infections. Dosage for dogs 13.75 mg per kg every 12 hours. For cats 62.5 mg per cat every 12 hours. Route oral. Presentation 1 into 10 tablets. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
Or sometimes the alveolus is filled with exudates. So the lower respiratory tract disorders produce expiratory dyspnea. So now I have mimicred these two things. Inspiratory dyspnea. This is inspiratory dyspnea. Then this is expiratory dyspnea because air cannot easily come out. So that is then the third dyspnea is a restrictive dyspnea that I have mentioned yesterday. These are the three types of dyspneas because a restrictive dyspnea means the thoracic cavity is full of water. Thoracic cavity is full of water. There is lot of water. There is lot of fluid inside the pleural cavity. That is severe pleural effusions. So what will happen? The lung will be compressed. Quite natural. Lung will be compressed. And so what will happen? Inspiration becomes impossible. Expiration is possible. Okay. But inspiration means no, it cannot, because it cannot expand too much because there is too much of water fluid inside the pleural cavity. So that is inspiratory dyspnea. That is a restrictive dyspnea. So the pleural effusion is restricting the lungs to expand more. That is a restrictive dyspnea. So we should think about these three technical terms. Then coming to how will you diagnose? Suppose you suspect a lung disease due to these symptoms. Okay, these symptoms are there. You suspect it. How will you diagnose? What we have to diagnose the lung disease or the respiratory disease. Ultimately, we have our brain, we have our two hands and a stethoscope. That is all that we have just normally in any clinic. So we know very well how to diagnose a disease. We have a methodology of clinical examination. Which are the methods of clinical examination? We all know. Before touching the patient, go near it, do like this and observe the animal. Okay, what is it? Observation. Inspection. Inspection. Okay, then go near it. Touch and see what all things happened. Oh, there is a bumping, there is a swelling, there is a dip, the skin is rough, like that. So you can feel it. So there is palpation. Then you tap it and listen to the sound from inside. Tut, 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 tun, 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 tun. Poop, 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 poop. Tom, 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 tom. Tap, 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 tap. So these sounds are there. When it's tap, 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 it is dull. So something is solid inside. The dullness is there. Tum, 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 tum. Yeah, it is air filled. The cavity is air filled. So the resonant sound is there. So that is percussion. By that, see, I will come to the basic clinical examination class is coming. I will detail everything. It is so interesting. So we can go out and percuss the lung. Sometimes the lung is full of edema. You will feel the tup, 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 the dullness will be felt. Otherwise, normally lung is sponge-like. It has lot of air inside. It should be tum, 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 like a football. But unfortunately, due to the water inside, you can feel that dullness, tup, 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 tup. So that is percussion. Then the next method of examination is auscultation. By auscultation, the old fathers of medicines, they auscultated. Auscultation means just listening to the sounds from inside by placing the ear. Listening to the sounds. Okay, what they did, they directly placed the ears over the chest. We cannot go and place the chest over a lion which is having dyspnea or a biting Rottweiler which is having dyspnea. Can we? No, no, that will be our last clinical examination. So, what should we do? For that, we have other methods of auscultation. We can use direct auscultation and indirect auscultation. For that, indirect auscultation, we use our stethoscope. Okay, that is indirect auscultation. And auscultation is a must in diagnosis of a respiratory disease. Now we are concerned, right now, we are concerned with the lung disease. Auscultation is essential. Without a stethoscope, we cannot do anything. One of my friends called me, Vinod, you give me an immediate answer. Now I have conducted oophorohysterectomy in a national. Okay, good. I want a precise answer immediately. That is why I called you. Yes, you asked me. Then now, after the surgery, it is not moving. There is no respiration, nothing at all. I asked him, you fool, you have done a big laparotomy and now it is not respiring, means you are phoning to me. You immediately give the resuscitation. Why you are phoning to me? Use your logics. See, auscultate and see whether there is any heartbeat, other it is gone, dead. He said, I don't have a stethoscope. Oh, I got too angry. But before telling anything, I cut the phone. Otherwise, I would have shouted to him like anything. I cut the phone. So I thought, without even the stethoscope, he anesthetized the dog, performed a laparotomy, performed the whole surgery. He said that he removed the whole genitalia. Now I believe he would have removed some intestine part or something. I don't know. That was a two hell. That day was a very bad day for me because why he asked like the stethoscope. It is a basic need of a veterinarian. Not only the veterinarian, for a doctor, it is a basic need. Even the BHMS graduates, the homeo, Ayurveda, Siddha, naturopathy, these are all medical colleges. And they were actually against this stethoscope. But nowadays, they have come to know that stethoscope is needed for the basic clinical examination. And now they are also auscultating their patients. So for physical examination of the lungs and the respiratory system, we definitely need a stethoscope. So that is regarding the physical examination. You can auscultate and you can percuss. There is no need of palpation because you cannot palpate. It's a visceral organ. So, but we can inspect from a distance. The restrictive dyspnea, inspiratory dyspnea, expiratory dyspnea, all can be before touching the patient from a distance itself. You can examine what type of dyspnea it is. Is it normal thoraco-abdominal type? Is it a thoracic type? Is it an abdominal type? Then types of respiration such as Biot's respiration, Cosmol type respiration, all these things. In a critically ill patient, a Cosmol type respiration. Pause. Pause. A Cosmol type respiration. Cosmol type respiration. That gives an unfavorable prognosis. Whatever you ventilate. So, whatever you ventilate. So, thorough auscultation, before that, thorough inspection is necessary for diagnosing a respiratory disease. Now we are concerned with the lung disease. We can go for more advanced things. Generally, most of our private veterinary clinics have radiography. Better to take an X-ray. X-ray of the lung will give you certain important clues for the lung. Maybe lot of air inside, outside the lung. We can say it is pneumo-abdomen. Lot of fluid inside the pleural cavity. We can say it is pleural effusion. Sometimes a lobe itself will be twisted. You can say it's a lobe torsion. So many things. Inflammation, edema, rupture, lot of things can be drawn out by a clear radiograph. Scintigraphy is related to the nuclear medicine. I just wrote it because it is all written. Everything is being taken from standard textbooks. That is why I have written it. I am not going into scintigraphy at all. Then the bronchoalveolar lavage. Bronchoalveolar lavage means we are anesthetizing the patient. It is having chronic cough. We do not know what exactly the disease is. So what we will do? We will introduce the endotracheal tube, anesthetize the patient, introduce the endotracheal tube. Through the tube, we are infusing saline into the bronchus or the lower tracheal region, immediately aspirating the infused saline, so that the saline will contain certain cells which are washed from that mucosa. Otherwise, we cannot take it. So washed from that mucosa. This is the bronchial wash or the bronchoalveolar lavage. So we can do it. So by this, we have to oxygenate the animal. So mostly when we are anesthetizing the animal with severe dyspnea and a chronic obstructive pulmonary disease, etc., we should be very careful because hypoxemia can happen, cyanosis can happen, death can also happen due to asphyxia. So we should be very cautious. So that is bronchoalveolar lavage. It is said in textbooks. It is taught by all respiratory physicians, but better not to try it because it is very dangerous. Then, if at all you want to aspirate some fluid, let it be from outside the respiratory tract. Let it be from the pleura. Just poke some needle with all aseptic preparations. Aspirate it. You will get some fluid. You say those are the pleural effusions. Centrifuge it well in 5000 RPM. Okay, you can see that there is a decant. and there is a supernatant. Pour out the supernatant fluid, you will get the decanted material. It contains the cells. If at all it is a lung tumor, those malignant or neoplastic cells will be in that fluid. Then ultimate is a lung biopsy and thoracoscopy. Ultimately, if we are not able to find anything, we are doing all the tests, but we are not able to diagnose what it is. The same biopsy needle can be introduced. The Wim Silverman needle, where you take the biopsy of the liver, it can be introduced into the lungs through the intercostal space, and you can take out a true cut biopsy, send it for histopathology, see what it is. But the chance of pneumothorax is more, because you are rupturing or you are piercing the lung. The chance is there. Thoracoscopy, of course, it is inaccessible to us. But the simplest thing that we can do is auscultation. Of course, not like the previous doctor which I mentioned. All of you and me, yesterday I displayed all my stethoscopes. I have 7 stethoscopes. Out of these, 3 are Littmans. 2 are Littman Classic 3, 1 is Littman Classic 2. Somebody asked me, some friends asked me, why you are frightening the people by showing all these stethoscopes. As a joke, I said, this is for the auscultation of the heart, this is for auscultation of the liver, this is for auscultation of the kidney, this is for auscultation of the abdomen, this is for the thorax, this is for the hind limb, this is for the forelimb. Simply, as a joke, I said. So, auscultation is a must, and we need a stethoscope. That too, a quality stethoscope. I always prefer a Littman stethoscope. Littman. Little bit expensive, but it is worthy. So, regarding auscultation, it is the same on both the sides. What I used to do is, for chest auscultation, for the lung auscultation, it is better we divide the whole chest area into 9 compartments. The upper 3 compartments like this. The upper 3 compartments, the middle 3 compartments, the lower 3 compartments. So we can name these compartments also. The left side and the right side. The left upper anterior compartment, the left upper middle compartment, the left upper posterior compartment, the left middle anterior compartment, the left middle compartment, the left middle posterior compartment, the left lower anterior compartment, the left lower middle compartment, the left lower posterior compartment. So 9 compartments. Likewise on the right side, 9 compartments. So there are 18 compartments for auscultation on both the sides. See how interesting it is. At least we can say that the compartments, I have heard crepitation over the upper posterior left compartment. That is clear. Left upper posterior compartment. It is clear there is emphysemator sounds. That means it is the area of the left caudal lobe. Area of the left caudal lobe. So that means there is some rupture of the alveolus of the left caudal lobe. That means there is an emphysematous sounds produced from that area. So we can turn to that side. We can pinpoint the lesion. We can describe somebody we are describing means we can describe the lesion. This is found on this area. So also, see in this picture, area number 1, that is the upper anterior compartment. This is the area for the auscultation of the bronchus. Area for auscultation of the bronchus. Then again, area number 2. This we can auscultate for the bronchioles and also the alveolus. Area number 3, 6 and 9 purely for alveolar vesicular sounds. Yesterday we studied about the 3 normal sounds and 5 abnormal sounds. Which are the 3 normal sounds? Bronchial murmurs, bronchiovesicular murmurs and vesicular murmurs. The bronchial murmurs can be well auscultated in the number 1, bronchiovesicular in number 2 and vesicular in number 3, that is the peripheries of the lung. Number 4 and 5 can be used in bronchial and bronchovesicular, but mostly in cardiac auscultation. So all these areas are very important when we auscultate. So the same is on the right side also. This I would have demonstrated before you if it was a seminar. Since this is a webinar, I am not able to demonstrate. I can only give a pictorial study. See on this Labrador, this is another method of auscultation. On this Labrador, you can auscultate the areas number 1, 2, 3 and 4. Number 2 and 3, you can suggest the areas for bronchial and bronchovesicular. And number 1 also for bronchial and bronchovesicular. And even you can listen to the sound from the trachea in number 1. Number 4 is for vesicular murmurs, vesicular sounds. The same is that on the left side also. This is the right side. So this is also area of auscultation. If the auscultable area is more, it is quite normal in large, deep-chested dogs. Then you can auscultate the dog which is sitting on the ground like this. You will also have to sit on the ground and examine. But very heavy people like me, sitting for a long time on the floor becomes very difficult. So it is according to your comfort. We can lean down or sit down like this and examine. It's according to your willingness of the body or your physical fitness. So now the doctor is examining the boxer very nicely, which is sitting on the floor. Now he is examining in which area, you know. This is according to my first picture, number 5. That is a left middle window. Left middle window. Okay. And middle window is for the auscultation of the bronchial murmurs as well as the bronchovesicular murmurs. So also abnormal sounds can be auscultated. Which are the abnormal sounds? Crackles mainly. Fine crackles and coarse crackles. Crackles as if you are grinding or you are manipulating a plastic paper. crushing a plastic paper. That is crushing, that is crackling or crackles. A crackling sound. So as you are drinking a small bottle of Pepsi. After drinking a small bottle of Pepsi, what will you do? Will you throw it away? No, it is not allowed. What will you do? What should you do? You should crush it. Okay, when you are crushing, you will hear that crackling sound. It is somewhat similar to that sound, what is heard as crackling of the lungs. Abruptly, inside the lungs, what happens? All the alveolus and the bronchiolar mucosa, everything will be sticking on together. It will be obliterated due to the exudate, sticky exudate. When the forcefully air enters, as we all know, it is an active process. Inspiration is an active process. As when forcefully air enters, it will dilate, it producing a pop sound at the dilate. Only it is not a single pop sound from a single alveolus. Thousands of such alveolus will pop out. So that popping sound of thousands of alveoli produces the crackles. And it varies depending upon the degree of infection, producing fine crackles or coarse crackles. Then we have abnormal sounds like rhonchi, that means rails. We have the moist rails as when the air is being passed through wet tubes. Dry rails when it is passing through dry tubes. So moist rails and dry rails. Then emphysematous crepitations. All these can be heard. These are all abnormal sounds. Sometimes we do like this. Auscultation can be done like this. See, generally I used to do like this. I used to lean down and then auscultate. And in large dogs only, Great Danes, Dobermans, etc. But beware of the temperament of the dog, because by this time Dobermans are very dangerous and their bite is also very ferocious, very furious bite. They can bite you like a crocodile. Once, see, if there is one person who has got bitten by a Doberman, he will know how powerful the jaw of Doberman is. So you can auscultate, you can get lot of things while it is in the standing position rather than sitting. And adult Doberman, if it is a male, it will be something around 40 kilos. Lifting him on and placing on a table may be very difficult for the client, because two clients may be coming. The husband is 65 years old. The wife is 60 years old. What can we do? So in such a condition, we can make him stand like this, go near him, slowly pat him, and don't tap on him. Slowly pat him and rub him on the head. And then make him friendly. Let him believe that we are not going to hurt him. Then auscultate him like this. But while auscultating, we should be very particular that we are using a stethoscope which has a long pipe. Tubing should be long, because in veterinary we need that. In large animals, for example, we are going near the large animal, we should keep a safe distance of our head, because the large animal is having, the cow is having, or the ox is having a very large horn. It will be simply turning its head like this. Horn, if the tip of the horn touches our face, that portion is gone. So we should be very cautious. Even the ox may not be knowing it. For buffaloes, the buffalo's horn is very long and backward directed.
Hatvet Pharma launches its Hatpod range. Hatpod, Cefpodoxime 100 mg 200 mg dispersible tablets, Cefpodoxime 100 mg per 5 ml oral suspension. The safe and effective choice for stubborn infections. Cefpodoxime Proxetal dispersible tablets, Hatpod 100 DT and Hatpod 200 DT tablets. Cefpodoxime oral suspension, Hatpod 100 DS. Cefpodoxime Proxetil 100 mg per 5 ml. Indications: Cefpodoxime is used in both dogs and cats to treat a variety of bacterial infections, including skin infections, wound infections, bone infections, pneumonia, and bladder infections. Dosage for dogs: 5 to 10 mg per kg once daily for 5 to 7 days. For cats, 5 mg per kg once every 12 hours or 10 mg per kg once daily. Route: oral. Presentation: 1 into 10 tablets. For syrup, 30 ml. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
It can use like a sword. So also the dog. There are potential dangers. So use a stethoscope which is having long tubes. So it can be kept on the floor itself and then auscultated like this. Of course you can do it, but you should be courageous. Otherwise, if you are not very courageous, ask the client to keep him on the table. Then come and comfortably examine. I have seen some people coming in front and then auscultating from the front. Never do it. Never auscultate from the front. Always approach through the rear side, the back side, and then auscultate from the back side only. What all things, if you want to examine the brisket region, auscultate the brisket region, okay, put your hand like this and then place a diaphragm of the stethoscope on the brisket, thoracic inlet, and then auscultate. Otherwise, small breeds are also unpredictable. We all know Dachshunds, Lhasa Apso. Sometimes even the pug becomes unpredictable. Pug may bite. I've been bitten by pugs. I've been bitten by Shih Tzus. I've been bitten by Pekingese. Then the notorious small creatures like the Chihuahua, miniature pincher. Miniature pincher will bite like anything. You know it very well. Almost all the miniature pinchers will bite. Then Spitz. Pomeranians seldom bite. Spitz normally, very usually bites. Dachshunds. So we should be very cautious while auscultating. We should know the temperament of the dog, the breed. We can auscultate a Saint Bernard without any fear because he is so lazy and lethargic, he will never bite. He doesn't want even to open his mouth, that much he is lethargic and lazy. See, for biting means he has to open the mouth and then bite. He cannot do it, he is so lazy. If somebody bites for him, he will be happy. So, when you are auscultating the lung, we can hear the crackles or the wheezes. I said it is crackles, of course, like twisting and crushing the empty mineral water bottle. Then the wheezes, the musical sounds on inspiration. These musical sounds. These musical sounds are coming out. This musical sound, the wheezes sometimes can be audible with the ear. There is no need for a stethoscope sometimes. It will be well audible outside. And sometimes you can see, you can hear between respiratory sounds a brub 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 sound. Brub 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 brub. As if you take A broken balloon piece. Introduce your finger, release your finger, make a small bubble. Likewise, you may see, you wet this balloon bubble, rub it on your wet hand. Click, 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 one sound is heard. Not exactly like that. That is the sound produced by pleural and pericardial rubs. Got it? So the pericardium is rubbing onto the inflamed pleura. Okay? This rubbing occurs when the lung expands and then contracts. That is known as a pleural rub or the pericardial rub. And if there is a dull sound, very feeble dull sound, or if sometimes for a lot of time you are searching for the lung sounds and no lung sounds are there, you are too much tensed. Now I am inefficient to find out a lung sound. No, it may not be like that. Lung sounds are not audible in that particular case. You may be thinking that, oh, either I am inefficient for diagnosing the lung sound or my stethoscope has gone wrong. It may not be. It may be due to that something masking the lung sounds. Some barrier is there between your stethoscope and the lung, so that it is masking the lung sound. You cannot hear any lung sound. For example, pleural effusion. If there is a water bag in between, that is a pleural effusion in between, we cannot hear any lung sound. In severe pulmonary consolidation, see how the sound is produced. Yesterday I told, sound will not be produced. See, inside this room there is an air conditioner. No air is moving. I cannot hear any whistling sound. If I go out now in Kerala state, it is rainy season, raining like cats and dogs outside. Heavy rains are going on. Wind is also there. So I will hear that swishing sound of the wind. Why? Because there is air movement. And inside the lung also, when the air is moving, it will have a friction or rubbing onto the mucosal surface of the respiratory tract. This produces the vibration in the mucosal tract. This will be transmitted onto the chest wall. We hear it on the chest wall. That is an auscultation lung sound. So if it is consolidation, then there is no air movement. There is no lung sound. Then next is pneumothorax. In pneumothorax, lot of air will be expelled out into the thoracic cavity, in between the pleural sacs. It will be accumulated inside the pleural sac or the pleural space. In high pressures, it will definitely mask the lung sounds. There is a barrier in between the stethoscope and the lungs. So lung sounds can be masked during these three phases. Number one is pulmonary consolidation. Number two is pneumothorax. Number three is pleural effusion. Okay. Then there may be some harsh lung sounds because the respiratory tract, the tubular respiratory tract is narrowed due to inflammation or hypertrophy of the mucosa or edema of the mucosa. The lumen itself has completely obliterated and the movement of air becomes very difficult. So with much difficulty air is being passed. So a harsh sound occurs. So we say it is asthmatic. Sometimes in that harsh sound itself, a wheezing sound also can be heard. So asthmatic sound. Generally, if there is an upper airway obstruction, you see this chart, according to anatomical classification, these are the causes of respiratory distress. If there is an upper respiratory or upper airway obstruction, for example, in brachycephalic airway disease or in laryngeal paralysis, the breathing pattern will be inspiratory dyspnea. As yesterday itself I told, if it is upper respiratory tract obstruction or upper airway obstruction, inspiratory dyspnea occurs. And if it is lower airway obstruction, expiratory dyspnea occurs. And now with the mimicry, I showed you how expiratory and inspiratory respiratory dyspnea occurs. So in upper airway obstruction, there will be inspiratory dyspnea and externally audible noises such as stertors and stridors. Yesterday I well told you how stertors occur, how stridors occur. Stertors are more loud and intensified and noisy than stridors. Stridors are musical sounds. So, in lower airway obstructions, such as in asthma, whenever a cat is coughing, it will be asthmatic. In lower airway obstruction, there will be expiratory dyspnea. This is expiratory dyspnea. Got it? It is forcefully expiring, struggling to expire the inspired air inside the alveolus. So there will be extension of the lung, extension of the head. So that is lower airway obstruction. Then if it is a pulmonary parenchymal disease, such as pneumonitis or pneumonia. So in pneumonia, pneumonitis means interstitial lung disease. In pneumonia, interstitial lung disease, in pulmonary edema, and in pulmonary contusions. Pulmonary contusion means whenever there is a motor car accident, run very fast and hit the dog. What will happen? The severe hitting trauma of the chest. Immediately a concussion occurs inside the chest, a contusion occurs, and there will be crushing of the pulmonary parenchyma, producing severe inflammation and edema. That condition is known as a contusion. There will be hemorrhage, etc. Definitely out of this trauma, definitely vessels will break up. In such cases, what will be the breathing pattern? Definitely it is not consistent. Maybe rapid, maybe shallow, or maybe both rapid and shallow. And have both inspiratory and expiratory components. That is regarding a parenchymal disease. If there is a parenchymal disease of the lung, and if there is a vascular disease of a lung, and it is not so common, and we cannot diagnose it also in pulmonary thromboembolism. So in such cases, always it is not specific. A typical breathing pattern will not be there. Any breathing pattern depending upon the lobe affected, side affected, etc. Then in a pleural disease, such as a pneumothorax or pleural effusion. Pneumothorax means air inside the pleural space. Pleural effusion means fluid inside the pleural space. So in both these conditions, collectively known as a pleural space disease. In pleural space disease, there will be inspiratory dyspnea, rapid shallow breathing, or generalized paradoxical breathing. reduce lung sounds on auscultation, that we told. It's not only inspiratory dyspnea, it will be restrictive dyspnea. We should say it is a type of restrictive dyspnea, restrictive dyspnea. And in flail chest, of course, yesterday we mentioned about the flail chest. What is a flail chest? It's a typical respiration pattern when there is motor car trauma and the trauma of the chest wall, where more than two rib, particular segments of the rib is fractured and crushed, so that a big depression is developed on the chest wall. It's not a hole, through and through hole, it's a depression due to the complete fractured ribs. In that condition, a typical respiration arises. When it is on lateral recumbency, we can easily notice it. I will show you the video of a flail chest. So in this condition, we can see during inspiration, naturally the chest should expand. But the chest will be expanding, but this area of trauma will be depressing. It will be going inside. That is a typicality. Then why it is expiring? Naturally the chest compresses, but this area will come out, a bulge out. I'll show you. See, this is flail chest. See, I think I should reduce the speed of this. Let me see how far I can reduce the speed. If I am reducing the speed, I think in this speed we can appreciate it more. See, the paradoxical breathing. There is a trauma, and in this area you can see, this is a trauma where there is a rib fracture. See, this is the area of the rib fracture. This is a depression. See, this is the expiration phase. Inspiration, expiration. Inspiration, expiration. Inspiration, expiration. Inspiration, expiration. Expire. Inspire, 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 expire. See, during inspiration, the thoracic cavity is expanding. I will again reduce the speed. I think it will be much better if we reduce the speed. Now this is the flail chest. So regarding that was a flail chest, and flail chest is very commonly met with in traumas, accidents. And so the breathing pattern is like this. It will be having a focal paradoxical breathing. Focal paradoxical breathing. In severe abdominal distension, what will happen? In ascites and organomegaly, there is severe abdominal distension. So what will happen? This distended organ due to ascites or a severe hepatomegaly or a splenomegaly, this will be increasing the convexity of the diaphragm, pushing the lungs forward, and while expanding, this will not goes back. This will not go backwards, so that the lungs cannot expand too much. So that is regarding abdominal distension. There will be, see, expiratory dyspnea will not be there, quite natural, but there will be severe inspiratory dyspnea because the lung cannot expand due to the severe organomegaly inside the abdominal cavity, or maybe due to severe ascites. This is quite natural, we used to see it. But physical examination of us is auscultation. We should listen to the rate, rhythm and sound of the heart and lungs. Normal resting heart rate, normal respiratory heart rate. The rhythm, listen for the normal sinus rhythm, okay, abnormal sounds in the lungs like crackles, wheezes, evidence of respiratory distress, flared nostrils, open mouth breathing, respiratory striders, etc. All these things we have discussed. Let us go through some common chest diseases. Some common chest diseases, which is very commonly presented in our clinic. One is canine distemper. As we all know, my dear friends, canine distemper, we have the adenovirus, and this virus is a pantropic virus. We all know very well. It affects all the systems. And of course, in most of the cases, it will start as a fever. Immediately, it will go to the neurological form before all these symptoms. But it is a pantropic virus. It affects all the systems like the hepatobiliary system, gastrointestinal, nervous system, integumentary system. Everywhere it will be affecting. And so there will be, when it is affecting the GI system, it produces vomiting and diarrhea. Integumentary system, producing gum-covered eyes. There will be a lot of ocular purulent discharges. Mostly there will be corneal opacity, anterior uveitis. There will be keratitis, skin disorders. And so, after the first phase of viremia, there is a secondary phase of fever. That is why we say as a biphasic fever in canine distemper. Biphasic fever. During the second phase, it will show a fever with severe bronchopneumonia. During that time, we can see pus will be oozing out through the nostrils. The entire respiratory tract will be affected with severe inspiratory dyspnea. On auscultation, you will be definitely hearing that crackles. There is severe bronchopneumonia. Bronchitis, cough and bronchopneumonia will be there. So, we know regarding the treatment of canine distemper, there is no treatment. It's a viral disease. We can only treat against the secondary bacterial infection of the lungs, the respiratory system. But at the same time, we are all concerned, as like you, I am also a private veterinarian. I am very much concerned about contagious infectious diseases in canines presented into my clinic. So if I see that it is a parvo or a distemper, Like you, I will not entertain because it is contagious. We cannot suffer. So we give, somebody will ask you, which is the best antibiotic for the lung disease or the chest disease? Of course, for the respiratory system, the best is broad spectrum penicillins. It has a good coverage of all gram positive and gram negative organisms. Staphylococcus will be there, Pseudomonas will be there, Corynebacterium, E. coli will be there. So, anaerobic bacteria may not proliferate because always air is coming inside. So, anaerobic bacteria cannot proliferate, like Clostridium, they cannot proliferate. But otherwise, all other organisms, such as all those mentioned by me just a minute before, they can proliferate. So, if we are giving
Hatvet PHARMA introduces Hatcot MP, methylprednisolone 8 mg tablets, the ultimate power of glucocorticoids in more potent form. Methylprednisolone tablets, Hatcot MP tablets, glucocorticoid systemic drug. Indications: anti-inflammatory and immunosuppressive. Dosage for dogs: 0.5 mg to 1 mg per kg per day. For cats, 1 to 2 mg per kg per day. Route: oral. Presentation: 1 into 10 tablets. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
a third generation cephalosporin, like ceftriaxone, it may not be effective because it has a narrow spectrum of action. Aminoglycosides, they have a narrow spectrum, like gentamicin, kanamycin, amikacin, tobramycin. All these are having a narrow spectrum because it is those things, third generation cephalosporins, then aminoglycosides, etc., have a narrow spectrum which is mostly active against gram negative organisms. Tetracycline is a perfect broad spectrum antibiotic. It can be given, but unfortunately it is nephrotoxic. Then we can go for quinolones. Of course, enrofloxacin, ciprofloxacin are megaspectrum antibiotics which can be used. Then the best is broad spectrum penicillins. And among that, the best is amoxicillin. Among that, the best is amoxicillin potentiated with either a cloxacillin or tazobactam or sulbactam. Or orally we can give mox potentiated with the synergist, that is clavulanic acid. It's also a megaspectrum antibiotic. So the best is broad spectrum penicillin. So we can use the broad spectrum penicillin. In canine distemper, secondary infection can be happening due to a group of organisms, among which the main is Bordetella bronchoseptica, different strains. Even Bordetella bronchoseptica is a gram-negative bacteria, but different strains are there. Even a single antibiotic cannot cover all the strains. And also Corynebacterium, Pseudomonas, Streptococcus, etc. will be there in secondary infections of distemper. So, broad spectrum antibiotic is a must. Then what all things can be given? Never give any diuretic in infectious diseases of the respiratory system, because If you give diuretic in non-infectious conditions, of course, if it is pulmonary edema due to a left-sided heart failure, definitely we have the 4D treatment. The treatment in the Merck veterinary manual itself says that you should give 4D. Diuretics is a must, especially the loop-acting diuretic. Otherwise, in this infectious condition, don't go for a loop-acting diuretic here, because in such conditions, it will not be eating or drinking anything. Naturally, it will be dehydrated. In severe lung diseases, you cannot give any IV fluids also. So IV fluid therapy should be restricted. So in such conditions, if you are going to give a diuretic, what will happen? You are wasting all the natural body water. Why you are doing all this crime? So don't do it. Don't do it. That is a simple logic behind it. So that is canine distemper. Then another thing is that canine distemper, of course, it is a disease which cannot be easily cured, you know very well. Then is COPD, the chronic obstructive pulmonary disease. See, it is not a simple disease. Like in human beings, it could be a big issue. And in respiratory medicine, after all the issues, the person was in the spray painting factory. He is in the boiler department. He is inside the bakery. Or he is always, for the last 25 years, he has been doing his work on road tarring. So all this work in human beings will produce lot of fumes and smoke, carcinogenic materials, irritating materials which he is always inhaling, continuously irritating the respiratory mucosa, especially the lower respiratory mucosa, for a very long time. And what will happen? Due to irritation, it produces hypertrophy of the mucosa of the lower respiratory tracts. And what happens? At last, it becomes an irreversible condition by which he is always having inspiratory dyspnea. Then he will approach the doctor. He says that it is COPD, there is no treatment. You go on with some corticosteroids, go on with some bronchodilators, respiratory stimulants, etc. Thereby you can extend your life. The same thing is in dogs also. If you diagnose it, see, COPD, it's a chronic disease. You cannot say that the dog is being presented to you yesterday and today you diagnose it as COPD. No. You have to observe the dog for a very long time. Then only you can say that it is a COPD. In COPD, it's a multifunctional disorder with multifactorial etiology or obscure etiopathology. We do not exactly know what has happened. We can ask a lot of questions to the owner. He may tell that, oh, it is in the roadside, always dust inside the house. He is in our estate. We have a lot of dust and fumes there. Maybe the reason of COPD. The treatment or management is same as that of the human beings, like immune suppression with the corticosteroids, bronchodilators, and this particular patient will be highly sensitive to allergens. Especially COPD can happen if the dog is being kept indoor inside a room where always, all the time, air freshener is sprayed. Air freshener is a big problem. Even to us also, don't spray too much of air fresheners. That is why I am also too much hesitant to be always inside the air-conditioned room. I don't like AC. Because I know, see, my wife and myself, one of our conflict is this thing. I need open air, well ventilated areas, but she needs air condition. So this is the thing, because all the expired air, all the fumes, dust, especially if we are spraying this air fresheners, and nothing is lost, it will be only inside. And we are not knowing it, you are always inhaling it, it is irritating all the time, and it ultimately produces COPD after a long time. Then the third one, I am taking too much of time in a single disease. Let me make a little bit faster, because I have a lot of things to tell. Lot of diseases are my very most very popular diseases, and my masterpiece subjects are there. That is why I am taking too much of time. And now let me be bit fast. Like infectious tracheobronchitis, we know the kennel cough. Again, we say that kennel cough is a group of organisms by mainly the same thing, Bordetella bronchoseptica. But it could be another strain of Bordetella bronchoseptica. And we know that during adverse conditions, this Bordetella, which is a normal commensal, which is one of the respiratory tract, will not be active and flared up. But when a suitable environment comes, like in the cold climates or misty climates, this can flare up in the respiratory tract and produce tracheobronchitis, that we call as a kennel cough. And this strain is well sensitive to doxycycline. I have always found that doxycycline is the best antibiotic of therapy against kennel cough. But the client, they need immediate relief. The cough makes the problem. Doctor, my dog is coughing like anything. No, I cannot bear with the sound which is made by the dog. Of course, that is good. At the same time, you are giving doxycycline orally BID. That is good. Along with that, an antitussive. Which antitussive? Antitussive means any medicine which is given against cough. Of course, for human beings, we can go for codeine, thebaine or anything. But the best I have ever found, nowadays I am doing this technique. I take the injection of butorphanol, 0.055 milligram per kg subcut, 1 or 2 injections. The cough will be suppressed. We can go for butorphanol injection. Butorphanol. We have in our theatre these ampules. So kennel cough. Then pneumonia and pneumonitis. Pneumonia means it is infection of the pulmonary lung alveolar epithelial borders. And due to that, inflammatory exudates, etc., will be collected inside the alveolus. So, an inspiratory dyspnea occurs. The tidal volume becomes less. The minute volume becomes less. Hypoxemia occurs, especially in pneumonia. If the dog is sitting always quiet, nothing will happen. But when it is excited, immediately the need of oxygen, the demand increases. So to meet the demand, the lung is restricted, and so what will happen? Dyspnea occurs. So exertion dyspnea. But cough, the exudates should be coughed and expelled. Cough is a clinical sign. The pneumonitis means it is parenchymatous inflammation. To a certain extent, this can be auscultated and found out. Pneumonia is more serious than pneumonitis. Pneumonitis produces edema of the pulmonary parenchyma, which compresses the alveolar pockets. So again, restriction takes place. Then lung tumors. Tumors of the lung are not so uncommon. Primary tumors or secondary tumors can happen. For example, There is a disease which is not so very commonly seen, but we have studied pulmonary osteoarthropathy, Mary's disease. The secondaries are found in the lungs. Then our very commonly found osteosarcoma, secondary tumors are found in the lung. In every osteosarcoma, it is mandatory that we should take a chest, lateral and video radiograph. So treatment depends upon the cause. Then brachycephalic airway syndrome in brachycephalic dogs such as pugs. Yesterday I mentioned about brachycephalic syndrome. Like there will be stenotic nails, there will be elongated soft palate, everted laryngeal saccules, etc. Surgery is the only beneficial method. Feline bronchial asthma, of course, there will be severe expiratory, not inspiratory, there will be severe expiratory dyspnea. You can see like heaves it develop and a sound it will be seen. So immediate relief can be done with nebulization with beta agonists like a salbutamol or terbutaline. Then we can give epinephrine adrenal injections, corticosteroids or the therapy. Aspiration pneumonia is very common when we are drenching the fluid, maybe the dewormer or the Li-52 wet liquid, whatever be all those fluidy medicines. When drenching, forceful drenching can produce, especially in brachycephalic breeds, this can produce aspiration into the trachea, goes into the lungs and sometimes produce pneumonia. Of course, it will be cupped and expelled out. But for the same time, if it is severe, like in the case of bronchial asthma, oxygenate it. In brachycephalic airway syndrome, feline bronchial asthma and aspiration pneumonia, if it is so severe and there is cyanosis of the tongue, give oxygenation. Oxygenate it. Oxygen plant is necessary in our hospital. Without oxygen plant, we cannot function. Antibiotic is necessary in aspiration pneumonia. Of course, I said what the antibiotic of choice is. Then pulmonary contusion, like a car comes and hit the dog. It is collapsed. Severe inspiratory dyspnea. Okay, there is contusion of the lung. Take an X-ray. You can see as if there is hemorrhage and pleural effusion. It is pulmonary contusion. It needs days therapy, but in pulmonary contusion or traumatic conditions of the trauma lungs, never give any IV fluids. Don't give any IV fluids, because if you give, it is my practical experience also. If you give any IV fluid in pulmonary contusion, it will die. Whatever you are giving, colloid or crystalloid or anything, hypertonic or isotonic, whatever you give, it will die. So don't give any IV fluids in pulmonary contusion. If it is dehydrated, let us wait. Let us wait slowly. Or if it is too much dehydrated, then slowly we will give some subcutaneous fluid. That is all. But not, I have said in my fluid therapy class, no any glucose containing fluid subcutaneously. Then antibiotics. We suspect hemorrhage, like there will be hemorrhage from the nostrils or hemoptysis. Go for styptics, adrenochrome or ethamsalate. And in smoke inhalation, this is a very dangerous thing. Too much of smoke in fire burns. When the fire is set up, too much of smoke is inhaled, because a dog doesn't know where to run. They will run hither and thither. They will inhale all the smoke. Smoke is an irritant. It will destroy all the epithelial cilia produces severe cough and bronchitis. So that sometimes the dog will be presented with severe cyanosis. Immediately oxygenate it. Put on the mask and then oxygenate it for hours together. Then only it will become normal. Go on with fluid therapy, antibiotic therapy, anti-inflammatory therapy, corticosteroids, etc. To a certain extent, we can save from smoke inhalation. There is severe lung injury, alveolar injury, then drowning. Drowning, of course. Drowning is not so common in dogs because dogs, God has given the power for swimming. We know the Rottweiler, Cocker Spaniel, Labradors, Golden Retrievers, all these are very wonderful swimmers. Even other dogs also, they know swimming. But I don't know swimming. I don't know. Till now, I'm 50 years old. I don't know swimming. But I wonder how these dogs studied swimming. Who taught them? I don't know. Anyway, it is nature's protection. Flood can occur. They will swim easily. So, drowning, maybe freshwater drowning, that is less complicated than saltwater drowning. If it is drowned inside the sea, where in Kerala state, it can happen because my Kerala state is entirely coastal. Arabian Sea is nearby. So in my place, this place, Kozhikode, my sea is just 1 kilometer away. Sea is just 1 kilometer away. Just 1 kilometer from my hospital. So people are taking dogs, not now due to COVID, people are taking their dogs to bath in the sea. If drowning happens and they drink lot of, it is going into the lungs, it is drowned, that means it is drowned and aspirated too much of seawater, it is hypertonic, lot of salt is there. Or fluid therapy is coming. All the body water, interstitial water will be drawn into the alveolus then. So the condition complicates. So oxygenation is the most important thing. If it is drowning, if it is drowned inside in the seawater, it is more serious. If it is in the fresh water, means we can give a lot of hypertonic fluids, so that after giving hypertonic fluids, giving diuretics, etc., to a certain extent we can go for relief of the pulmonary edema. Then dilatation of the bronchioles, like bronchial dilators, bronchodilators, then oxygenation, antibiotic therapy, etc. Those are then pulmonary edema. Pulmonary edema may be possibly due to a left-sided heart failure. Left-sided heart failure. So we have to take an ECG, go for auscultation of the lungs, heart. We can see that there is a mitral damage, valve damage. There is no treatment for mitral damage. If it's a mitral rupture or a mitral regurgitation or a mitral valve thrombosis, there is no treatment. We can wait and see. So then lung lobe torsion. Lung lobe torsion is not very common, but certain breeds with deep chested and it has lot of space inside the pleura. When the lung is floating in that, in some conditions, after running, etc., this can twist. The anterior lobes can twist. At its highness, it can twist. The blood will be sequestrated. The complete circulation to that area will be cut off. It undergoes necrosis. The only option is opening and removing that lung, lobectomy. You will be having too much of hemoptysis, severe dyspnea, inspiratory dyspnea, etc. And happens all on a sudden. X-ray radiograph can diagnose it. Idiopathic pulmonary fibrosis. This is not so common, but pulmonary fibrosis can be seen as a chronic pulmonary inflammation. Pleural effusion. Pleural effusion is very common. Effusion is very common in dogs and cats. Whenever pleural effusion is being presented, there will not be any lung sounds. If it is severe pleural effusion, lung sounds will be absent. And there will be severe inspiratory dyspnea, there will be restrictive dyspnea. In such cases, immediately go for pleural space aspiration. That we will mention tomorrow. How will we aspirate the pleural space? Then pneumothorax. In Kerala state, this is very common because hunting dogs are there, taken out for hunting.
Hatvet Pharma introduces Hatcot DS, Penicillin Sodium Phosphate 10 mg per 5 ml oral solution. The ultimate power of steroid with double strength. Penicillin Sodium Phosphate oral solution, Hatcot DS syrup. Glucocorticoid systemic drug. Indications: anti-inflammatory and immunosuppressive. Dosage for dogs: 0.5 mg to 1 mg per kg per day. For cats, 1 to 2 mg per kg per day. Route: oral. Presentation: 60 ml. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
Hunting dogs. They go for hunting porcupines. And porcupines, will they leave? No, they won't leave. They won't spare. They will fiercely they will throw their thorns. And thorn will penetrate the chest wall. And what the client will do, he will immediately remove it. So what will happen? Immediately air enters and pneumothorax of this. Immediately after that, it will show dyspnea. It will be rushed to the hospital. X-ray will clearly show the pneumothorax. So air aspiration, that is the only method. The immediate relief occurs after. I have done it several times. Aspiration of the air is the only measure to save the animal. After the aspiration of air, it will show immediate response, quick response. Pneumomediastinum. In pneumomediastinum, you go on with the antibiotic therapy, etc. All these things are well evident from the radiograph, lateral thoracic radiograph, but don't do any aspiration. It is always dangerous. Diaphragmatic pneumomediastinum. Mediastinum normally contains lot of tissues like the esophagus, the trachea, then other structures like the lymph duct, nerve, everything are having the same radio density. And when it is completely encircled by air in the mediastinum, this can be shown as distinctive. Clearly seen each and everything. Esophagus, the trachea, vagus nerve, etc. can be seen as very distinctive and very clearly you can see the mediastinal organs. So that is how we diagnose the pneumomediastinum. I will show you the radiograph. Then diaphragmatic hernia, of course, after a trauma, a road accident, immediately the diaphragm ruptures and all the abdominal contents, especially the intestines, will gush into the thoracic cavity. So severe dyspnea, inspiratory dyspnea occurs. It's a very serious condition, surgical condition by which we operate it. So diaphragmatic hernia sometimes can be hereditary or congenital in nature. See, I have a bitter experience. I was conducting, when I was running my hospital in Kochi, I was conducting a panhysterectomy, sterilization in a beach. The beach was very happy while coming there. I anesthetized the dog. Okay. The owner was also very happy. I anesthetized the dog. On dorsal recumbency, I operated, I put the first incision over the ventral abdomen. Or the first incision, I was also very happy. On the skin, nothing happened. Second incision, slow incisions on the subcutis and the subcutaneous fascia, nothing happened. I was also very comfortable and happy. Anesthesia was also fine. Next, I incised the linea alba. Upon incision of the linea alba, it slowly showed respiratory distress. And this respiratory distress increased as when I opened the abdominal cavity. The respiratory distress was too much where I could not control and I didn't know what happened. You know, in no time, in 1 minute, the dog died. I couldn't know. I didn't know what even happened. I was shocked because I know that the man who has brought the dog is sitting outside. What can I tell him? Oh, I was totally desperated, shocked and desperated. I didn't know what happened. After, I was too depressed. I sat for a while. The dog is gone, dead. For some time I sat on a chair. I thought, what should I do? He's sitting outside, expecting that immediately after surgery, after 10 minutes, it will be taken out. I came out. I said, I'm so sorry. What happened? So sorry, your pet is gone. What? Oh! You said, well, all these things I explained. But in no way he could be calm. He rushed and, he showered me with bad words like anything. So I'm bound to listen to it. What can I do otherwise? After working almost for half an hour, he shouted at me. What can I tell? Even I don't know what the cause is. Anesthesia was perfect. At last, after half an hour, he said that I will make this a big issue. I want to know what happened. So I said, we will conduct an autopsy. Okay, and then he calmed down a little bit. I conducted the autopsy and I showed him. I operated it. I performed the autopsy and I saw the congenital diaphragmatic fissure. The congenital diaphragmatic fissure, it was a hernia. The intestine, some part of the intestine was inside, but it was completely asymptomatic. Now what happened? I incised the abdominal cavity, air entered through the abdominal cavity into the thoracic cavity, all the lungs collapsed. Is it my fault? This can happen to you also. Tomorrow this can happen to you. Don't smile or laugh. This can happen to you also. Do you know? You don't know the pain which I suffered during that time. Because it was not due to my fault. And I suffered a lot. This man, he tortured me like anything for days together. But then he got convinced. We took the photograph. He took the photograph during that time. So, this is one bitter experience with in my practice. Mediastinal neoplasms can happen, like lymphomas, lymphosarcomas. There is no treatment. Of course, I have tried with the doxorubicin, but diagnosis is very difficult. Once I was conducting abdominal scan in a dog. It was a Doberman, deep-chested Doberman. I simply pointed. I couldn't know what has happened because it is having vomiting. I then pointed the transducer of the ultrasound towards, it was a gynecological transducer. I pointed it towards the mediastinum. I saw a lot of globular things. Then I could know that it was enlarged mediastinal lymph nodes. I aspirated. By a guided aspiration, I aspirated it. At last, I diagnosed that it was lymphosarcoma, mediastinal lymphosarcoma. Then the chest wall trauma, like what I have told, it produces pneumo-abdomen and pneumo-mediastinum. Flail chest, we saw it now. Foreign bodies in the airways. It is not so common because the epiglottis is always there to guard the larynx. Tracheal trauma can produce, a piercing tracheal trauma can produce escaping of the air and producing a massive subcutaneous emphysema. I've seen it several times, especially in pups. It will be presented as a pig. It looks like a pig and too much tensed skin with lot of tensed and pressured air beneath the skin. We have to cut open the skin several times in several places and then aspirate the air. It's very difficult to find out the perforation of the trachea. Maybe in the trachea, the perforation may be in the cervical trachea. If it is in the cervical trachea, of course it is good. Otherwise, if it is in the mediastinal trachea, there will be perforation. First, there will be forming a mediastinum, pneumomediastinum, and then the air escapes out through the thoracic inlet, then encircles the whole chest wall. It's very difficult to control this thing. I've seen it several times. And subcutaneous emphysema, just what I mentioned. Symptoms of the respiratory problems like cough, dyspnea, gagging after coughing. This is gagging after the cough. Nasal congestion, exercise intolerance, syncope. Syncope means sudden loss of consciousness and immediate recovery. Syncope, wheezing, cyanotic mucosa. These are the symptoms of respiratory disease. So depending on the condition, other symptoms may also be present like lethargy, fever, lack of appetite, and numerous other symptoms may also be noticeable even to pet owners. Let us study something regarding the radiographs. See, this is a lateral chest radiograph. The lateral chest radiograph may be the right lateral or the left lateral. It is very easy. For this radiograph, we can simply study. See, this is the upper side is known as the crura. These two areas, these are the two crurae or crus. We can say the crus. This convexity is known as the cupula. So the cupula, this whole liver is coming in this cupula. The cupula will be in touch with the apex of the heart. See, this is the cupula, this is the crura. And crura, say two crurae are there, two crus are there. And the left, this is the right crus, and this is the left crus, and this is the right crus. And see, you can see the crus, the borders of the crus are staying parallel to each other. If the borders are staying parallel to each other, it will be the right chest radiograph. Got it? This is how we can say that it is a right chest radiograph. If the borders of the crus are lying parallel to each other, it is a right chest radiograph. Here you can see the trachea, here you can see the heart, the vessels of the heart, and you can see there is pneumonia. There you can see the interstitial pattern of pneumonia. There is severe pneumonia and there is pulmonary edema. This is known as a carina. And so let us go to the left chest radiograph. See, is it like this? See the crus? The crus are like this, Y-shaped. The crura are Y-shaped. But the cupula is the same. But the crura is Y-shaped. It is not parallel. If it is not parallel, we can say it is a left chest radiograph. Here you can see a lot of things. You can see the trachea, you can see the carina, you can see the base of the heart, you can see the apex of the heart in touch with the cupula, you can see the caudal vena cava, you can see the aorta. All these things can be seen. There is an interstitial pattern, also there is a bronchial pattern of pneumonia. Then sometimes you take the ventrodorsal or the dorsoventral radiograph. How will you say it is ventrodorsal or ventral? If it is lying on the ventral belly on up, the X-ray beam is touching first the ventral region, then the dorsal region. It is a dorsal recumbency. That means it is a ventrodorsal radiograph. Or it is, if it is upright, if it is lying down and the X-ray is touching first the dorsum and then at last the ventrum, that means it is in ventral recumbency. Normal ventral recumbency is known as a dorsoventral radiograph. So dorsoventral and ventrodorsal. Ventrodorsal means like what the X-ray touches first. If the X-ray touches first is the ventral area, it is a ventrodorsal. If it is touching first the dorsal area, it is a dorsoventral. In the dorsoventral radiograph, it's look like this. See, I am telling you only one simple matter. You can see the diaphragm. Diaphragm only shows the convexity. See the convexity. And on the convexity, if it is an expiratory phase, you can see the apex is towards the left side and it is touching the cupula. Okay. Now on the ventrodorsal radiograph, you can see this is the expiratory phase of the ventrodorsal radiograph. You can see towards the left side, the apex is deviating. You can see the cupula and you can see the crus. The right crus and the left crus can be seen like this as the ears of a Mickey Mouse. So you can see the cupula on the top. This is the cupula and this is the right crus. This is the left crus. The right and the left crus can be seen as ears of the Mickey Mouse. That is how we can differentiate clear cell that it's a VD radiograph or a DV radiograph. Okay. See, this is a schematic representation of the. See, this is a right lateral radiograph where you can see the crus. The right crus and the left crus can be seen running parallel. Got it? But in the left lateral radiograph, you can see running as a Y, diverging, running as a Y. This is a right crus, this is a left crus. And in the DV radiograph, where dorsoventral radiograph, you can see only the cupula. We cannot see the crus here. But in the VD radiograph, you can see the cupula as well as the crus. The right and the left crus then can be seen as the ears of a Mickey Mouse appearance. Okay. See here in this radiograph, this is the area. This is the left chest radiograph. You can see the left chest radiograph. You can see the cranial lobe on the left side, the middle lobe on the right side, accessory lobe on the right side, and the caudal lobe. These two are the left lung. These two are from the right lung. Okay. Here also in this is a VD radiograph. You can see the right cranial lobe, the right middle lobe, right caudal lobe, the accessory lobe which is going towards the left side, the left caudal lobe, the left cranial lobule of the left cranial portion of the cranial portion of the left cranial lobe, the caudal portion of the left cranial lobe. All these can be appreciated here. Then sometimes you take an X-ray. See, this is X-ray on inspiratory phase. It is well expanded. The lungs is well expanded. You can see lot of air inside the lungs. If it is on the expiratory phase, it will be less air is there. So that also is there. We have to differentiate. This is a picture of bronchioalveolar lavage. You can see the endotracheal tube. It is an anesthetized dog. Endotracheal tube inside, and it is cuffed one. It's a cuffed endotracheal tube. It is fixed here, and we are introducing the catheter into this. Through this, we are using the catheter, and the catheter is fixed here. We are pushing some saline inside. Immediately after that, we are aspirating it so that we will get the lavage, where it contains the cells of this tracheal carina. Okay. Then the pulmonary function test, we have the spirometry, which we do not do it. We can go for interpretation of blood gas measurements. For example, we are studying it tomorrow. We are coming to hematology and blood biochemistry of respiratory disease tomorrow. Then pulse oximetry. I do have the small pulse oximeter which can be clipped onto the tongue. SpO2 can be determined. To a certain extent, SpO2, that is good. Always when you are anesthetizing a patient, or always when you are dealing with a recumbent patient in shock, whatever be it, poisoning or drowning or whatever it be, always see how far the SpO2 is. If the SpO2 is low, then definitely we have to give oxygen. Enteral capnography. The capnometer itself is very expensive. I did not buy it. Then carbon dioxide monitoring, of course. Then what is general management of respiratory diseases? We have to go with oxygen supplementation, airway hygiene, some twigs, leaves, etc. inside the airway, exudates inside the airway. We can aspirate it sometimes if too much of exudates. Positive pressure ventilation if we have it. Fluid therapy, but should be restricted always. See, in my fluid therapy classes, I have gone through certain pulmonary diseases, etc. which fluid should be given. But always restrict the fluid therapy in pulmonary diseases. If it is lung disease or if it is other diseases, of course you can do. If the lung is not clear, there's too much of crackles and wheezes are there, especially too much of crackles and bronchi, don't give any fluids. If there is no, if it is having no dehydration, why you are unnecessarily giving fluids if there is no dehydration, especially in this condition, this pulmonary pathology? Don't give it, leave it. So honor may tell that it is eating little bit. If it is drinking water, then leave it. Don't give any fluids intravenously. Then positioning is also very important. Better let it be on sternal recumbency, because if you make it on lateral recumbency, it may collapse sometimes. If let the dog take its own position, don't disturb it. Then drug therapies such as antibiotics, antitussives, corticosteroids, bronchodilators, antihistaminics, all these things according to the management. I told you. Antibiotics, especially we have the broad spectrum penicillins, we have the cephalosporins, third generation or fourth generation cephalosporins can be given. We can even go for oral cephalosporins. Then we can go for quinolones, megaspectrum antibiotics. We can go for aminoglycosides such as tobramycin, gentamicin, kanamycin, amikacin, etc. We can go for methyl xanthine derivatives such as aminophylline, theophylline, all these things can be given. Then glucocorticoids can be given. NSAIDs for pain and contusions, and the inflammations and edema. Antihistaminics, definitely antihistaminics are necessary in respiratory infections or respiratory pathologies. Expectorants to liquefy the exudates and then cough out decongestants into the nostrils, such as oxymetazoline and naproxen. Oxymetazoline spray is available. Nebulizers with salbutamol or terbutaline or all these nebulization drugs. Then common drug disease, lung diseases, we mentioned about bacterial pneumonia in dogs and cats, aspiration pneumonia we mentioned, pulmonary contusion we mentioned, smoke inhalation we mentioned, drowning, pulmonary edema, lung lobe torsion, idiopathic pulmonary fibrosis, lung neoplasms and flail chest. All these we mentioned, and now we are going to this pneumonia. Pneumonia we have the bronchial pattern, interstitial pattern, alveolar pattern, etc. See, we have this is the bronchial pattern. You can see the trump track appearance, and this is pneumonia. This is a bronchial. This is the pulmonary. This is alveolar pattern. You can see the trachea. This is emphysematous lungs. You can see the ruptured alveoli, emphysematous lungs. And you can see the diaphragmatic hernia through which all the enteric loops are there. Clearly it can be seen inside the thoracic cavity. So you can see the aorta here, the trachea here, the caudal vena cava here, the heart, and a heart encircled by this intestinal loops, diaphragmatic hernia. You can see pneumonitis. See pneumonitis, you can see the trachea and everything. Pneumonitis, the interstitial pattern. You can see the lung tumors, lot of lung tumors can be seen here, and all those are rounded here. These are lung tumors. Pulmonary contusion, it is a very serious condition. Don't give any fluid in this condition. Lung lobe torsion, it is also very serious. It is a surgical condition. The pneumomediastinum, the typicality of this pneumomediastinum means in the mediastinal organs can be clearly seen. You can see the trachea, you can see the esophagus. All these things can be clearly differentiated and seen. That is a typicality. You can see the pneumomediastinum. And the pneumothorax means you can see the air inside which elevates the silhouette, the cardiac silhouette, and you can see the completely filled up air inside the pleural cavity. This is the pneumothorax or the what is it? A pleural air, escape of the air into the pleural cavity. That's a pneumothorax. That's a pneumothorax. And pneumothorax always need aspiration of air from inside. It gives immediate relief. Then pleural effusion. In pleural effusion, always see if a chest radiograph, this is a chest radiograph, you can see the chest radiograph. In the chest radiograph, you can see if there is severe intensified shadows of the fluid in the lower areas with severe expiratory dyspnea, it is definitely pleural effusion. If it is a cat means, if it is showing a pulmonary chest radiograph like this, immediately you can simply take a scalp vein set and then aspirate. That much it is easy. Pulmonary fibrosis. It's a gone case if there is pulmonary fibrosis. There is a foreign body inside the trachea. It's a lower airway. Sorry, in the upper airway. It's a foreign body. And so sometimes if there is a tracheal rupture or tracheal perforation, air may escape into the mediastinum, or if it is cervical trachea, air may escape outside and air may escape onto the subcutaneous spaces, and you can see the air escape the subcutaneous spaces, and you can see the ballooned subcutaneous spaces. See, this is the air. This is it is a generalized subcutaneous emphysema. This condition is very, very difficult to manage. So now we are going to general management like the antibiotics, bronchodilators, corticosteroids, antihistaminics, nebulizers, oxygen supplementation, fluid therapy, and rest to the patient. Bharat Mata ki Jai. Now, thank you very much.